Good morning, good afternoon, good evening, wherever you are. Welcome to this event to celebrate International Women's Day. We're presenting the findings of research on gender and the reconstruction of health systems in post-conflict situations. This work was done recently, and the researchers wish to explore the topic further and are using the opportunity of this webinar and other opportunities to engage with a wider group of people, and also to share our new online resource, Building Back Better, which will be explained in the webinar. This webinar is co-sponsored by the RINGS Consortium, a group working on gender and health systems, and the thematic working group, the Health Systems Global Thematic Working Group on health systems in fragile and conflict-affected settings. We'll send these details of these co-sponsors later. This is part of a month of gender events that Health Systems Global is hosting, and there have been a number of Twitter chats, webinars and blogs that are all posted on the HSG website. Next slide, please. Let me introduce the panelists. Professor Valerie Percival from Carleton University will give an overview of the research. Dr. Sarah Sali from the Makerere University is part of the Rebuild Consortium, looking at health systems in post-conflict states, and she'll present a case study from northern Uganda. Esther Dusabe-Richards is from the Liverpool School of Tropical Medicine, and she will be presenting a case study from Timor-Leste. And my name is Tim Martineau. I'm from the Liverpool School of Tropical Medicine, co-research director for the Rebuild Consortium, and also part of the steering committee of health systems and fragile and conflict-affected states. And you're all welcome to join that. We have over 400 members in that group, so we'll send details of how to join. Next slide, please. So the program for today is Professor Valerie Percival will give an overview of the Building Back Better work. Then we have a presentation by Dr. Sarah Sali, the case study from northern Uganda, and this is followed by a case study by Esther Dusabe-Richards on the case study from Timor-Leste. And we're hoping that we'll have time for some good discussion at the end. You're invited to send your questions. These will be fed to us, and we have a sorting process for sharing out the questions at the end. And if there are ones that we don't manage to answer, we will first of all post the questions, but also over time try and answer questions through a blog or some method like that. So next slide, please. Just a couple of housekeeping rules that apply to all of these HSG webinars. Everybody will be on mute. Your method of communication will be typing the questions on the GoToWebinar panel. Please look for that slot. So as I say, we'll share out the questions as they come in, but we'll probably wait until all presentations have been done before doing that. As I say, we'll try and get back to you later with answers if we don't have time to cover your questions. If you've got a technical problem, please contact Natia. She's operating the system on behalf of Health Systems Global, and other support, contact Kate Hawkins. The details are there. So I'm asking my fellow panelists, please could you mute your microphones just to make sure there's no background noise. But Val, if you could unmute yours and start with the presentation.
Okay, thank you very much. Next slide, please. Thank you, Nadia. So thanks very much to Health Systems Global for organizing this event and inviting me to participate. I'm joining from Mozambique, so I hope that the internet connection holds. I'll be presenting the work that we did analyzing if and how gender was integrated into health system reconstruction and rebuilding efforts after conflict. And what we really want to do with this project is to present our findings in an effort to kickstart a conversation. And that conversation is about the role of the health sector in not only ensuring equitable outcomes in health, but also its potential in promoting gender equality in society. Next slide, please. So I'd like, next slide, please. I'd like to draw your attention to the availability of research articles and briefs on the website, www.buildingbackbetter.org. So my presentation is going to begin with a bit of background on the project. I'll review the issue of gender and conflict in the post-conflict context. I'll summarize our research, and then I'll describe some key challenges as we move forward in this research agenda. Next slide, please. The research is clear. Gender equal societies are more peaceful and more prosperous. The lack of gender equality is an important predictor of the level of state fragility. However, we don't know how to most effectively build gender equality within conflict-affected societies. Research suggests that the failure to incorporate gender into health system reconstruction misses an important opportunity to build more gender equal societies. And this opportunity has been missed because we inherently believe that health systems are somehow gender neutral. And health professionals working in these contexts have been focused on raising awareness of sexual violence and maternal morbidity and mortality, but they've often shied away from challenging gender norms that are driving that sexual violence and that maternal mortality. The political process in the post-conflict environment really focuses on increasing the number of women in the security sector, ensuring that they're able to engage in peace processes, and increasing their involvement in electoral politics. And all of this is important, but the relationship between gender and health systems has really been neglected. Next slide, please. So this research was a collaborative effort by myself at the Norman Paterson School of International Affairs, which is at Carleton University in Ottawa, the Rebuild Consortium, as well as the Stockholm International Peace Research Institute, which is also known as SIPRI. SIPRI convened a meeting in 2011 and formed working groups, and this research came out of one of those working groups. Next slide, please. So just to give you a little bit of a description of the context of gender in war-affected states, the experience of men, women, girls, and boys in war is really shaped by the social and cultural perceptions of gender norms and roles. Gender norms tend to devalue and denigrate women and girls, and they undermine and restrict their social status, their livelihood opportunities, their behaviors, and freedoms in many of these contexts. However, these same norms also encourage excessive risk-taking behavior among boys and men. They're initiated into a culture of violence and domination, and these norms prompt some of these men to embrace the role of combatant. The norms also impact on their health and their health-seeking behavior. Women, on the other hand, tend to be the objects of this culture of violence and domination. The breakdown in social norms, as well as the absence of law and order, increases the risk factors for sexual and gender-based violence. In addition, women's higher reliance on health services due to their reproductive and caregiving roles means that the war-related collapse in the healthcare system has significant consequences for their reproductive health and their ability to care properly for their children and other dependents. Next slide, please. The post-conflict moment is really seen as a moment of opportunity. And just to be clear, the definition of the post-conflict is fraught with ambiguity, and we use a standard definition utilized by political scientists, which is that the post-conflict period is the end of hostilities due to a victory by one side, a peace agreement, a ceasefire, or an end to hostilities by other means. And in this post-conflict context, donor resources are often readily available. Impediments to change, such as political disputes or vested interests, may be temporarily absent, and the political will often exists to build back better. Multilateral agencies and donors often undertake wide-ranging reforms of public sector institutions during this time. And for health experts, health sector projects can improve the quality and accessibility of healthcare and also increase the effectiveness and efficiency of the health system. And most post-crisis health systems are in clear need of reform. Infrastructure has been damaged or destroyed. Health workers are in short supply and often require skills upgrading, and population health indicators are problematic. However, the process of implementing those reforms is extremely challenging. Health systems are multi-layered and complex, and it's really difficult to find those magic bullet reforms that will result in both health system strengthening and population health improvements. Next slide, please. So the international community has undertaken several policy initiatives to address the gendered impact of war. Humanitarian actors have adopted gender policies such as the creation of the gender marker and the consolidated appeal process, and they focus more attention on the prevalence of sexual violence and the need to provide treatments for survivors of this violence. UN Security Council Resolution 1325 and its subsequent resolutions have been absolutely critical in putting key issues for women on the table. Their focus is on women in the security sector, women in peace processes, action against sexual violence, and promoting women into elected office. And while important, many of these actions have proven insufficient. They have not generated significantly better circumstances for women or girls or gender equality. So in our case studies, Mozambique and Timor-Leste have significant numbers of female politicians, and there's really been limited improvements in those gender indicators. The MDGs, now the SDGs, are another key avenue for engagement on gender and health. The MDGs focus much of their attention on maternal health, specifically access to services, rather than focusing on the upstream factors that are key drivers of maternal health problems. The SDGs call for universal access to health care, but the lack of explicit linkage between health and gender equality has been criticized. So as a result, in many places, rights for women and girls are stagnant, particularly reproductive rights. And there's been silence on the abuse. Next slide, please. So our project asked the following broad question: how does the rebuilding of health systems in post-conflict settings address an impact on gender equity? Our assumption is that the provision of health services is never gender neutral. Health systems reflect and they can also influence their social context. Health systems can therefore contribute to perpetuating inequities, or conversely can contribute to improving gender equality and enhancing equitable outcomes. While we've made every effort in our project to include information that shows the differential burden of ill health faced by men, the majority of our analysis focuses on the relationship between women's health and the health system. And this is a result of the frequency of interaction between women and healthcare due to the reproductive roles. But there definitely is a clear need to better identify how health systems can respond to the differential needs of both men and women. Next slide, please. So our research had two stages. Stage one, we asked two main questions. How gender sensitive is the reconstruction and reform of health systems in post-conflict countries? And what factors need to be taken into consideration in order to build a gender equitable system? And in stage two, we looked at specific case studies and we asked whether or not the rebuilding of health systems in those cases resulted in a more gender equitable health system. Next slide, please. So stage one took place between 2012 and 2013. We undertook literature reviews on health priorities in the post-humanitarian period, health system reform after war, health system reform in developing countries, and we also undertook some initial case study analysis in Timor-Leste and northern Uganda. Next slide, please. So stage one generated several key findings, and the publication that summarizes those website, Conflict and Health publication. In stage one, we found that there's a great deal of lip service to gender. In humanitarian settings, while the UN system has established gender goals as part of its consolidated appeal process, these are very shallow, and any project that addresses sexual violence or maternal health is counted as being gender responsive, and there's been little attention to addressing gender norms. We also found a widespread belief within the health literature that we call build it and it will be gender equitable, that the very efforts to build a stronger health system will therefore produce more gender equitable outcomes. There's been no definition of what a gender equitable health system is, and there's really no reflection on if and how the health system could be an arena to build gender equity in society. Next slide, please. So to fill this gap, under equitable system as one that has 5 components. First, it provides health services that address the most urgent needs of men and women across their lifespan in an appropriate manner. 2, it ensures women and men across their lifespan are able to access and utilize those services unimpeded by social, geographic, and financial barriers. Next slide, please. 3, it produces relevant sex-disaggregated health information that informs policy. Then it should also ensure equitable health outcomes among women and men and across age groups. And it should provide equal opportunities for male and female health professionals working within the health system. Next slide, please. In stage 2, we undertook more detailed case studies, which we're compiling in an article that should be available soon on the website. So in this research, we faced several challenges. Gender, politics, the economy, and the health system are all deeply endogenous. How can analysts distinguish between a weak health system and a health system that is gender inequitable, particularly in the face of poor data? And on the other hand, if we see improvements in health outcomes, can we interpret those positive health outcomes as being a result of a gender equitable system, or simply the result of broader improvements in the delivery of healthcare policies? Most of these contexts have such a low baseline that any resources being pumped into them will have some degree of result. So how do we approach the study of these cases? Next slide, please. So we decided that it was virtually impossible to disentangle the factors that cause weak health systems from the factors that contribute to gender inequitable health systems. But we didn't want that to deter us from our analysis of if and how health system reconstruction contributed to gender equitable health systems. So we decided to approach it differently. We applied our definition of a gender equitable health system as a benchmark, and we examined the degree to which health system reform in these particular case studies meets these benchmarks. Next slide, please. So these case studies confirmed the results of the literature review that health system reconstruction and rebuilding is really gender blind. Not surprisingly, all of the case studies fell short of being gender equitable. Gender approaches focused on addressing sexual violence and maternal health, not about transforming health systems to be gender equitable. The most gender-sensitive health reform effort, the reform where advocates tried really hard to integrate gender into the reform effort, was Mozambique. And there's been really disappointing results. And it's been a missed opportunity to utilize health system reform as a tool for change. So I'd encourage you to look at the briefs online for more information, and Sarah and Esther will go into more detail on their particular case studies. Next slide, please. So too much of programming in the humanitarian, post-conflict, and development context is focused on giving women tools like this app to find water. So I don't want to deny the importance of these kinds of tools, but what we really need to do is help women themselves change their context, and we're not really doing that, particularly in the health system. Next slide, please. So some analysts have expressed concern that utilizing the health system to promote gender equity would politicize the health system and overwork an already overstretched workforce. But we argue that health systems are a key interface for society. The population has with the health system and healthcare providers throughout their lifespan. In addition, the health system is a key employer in society. It's a respected social institution, and it has reach throughout a wide geographic area. So it is uniquely positioned to be able to address gender norms within communities in a way that other institutions would struggle to do. Next slide, please. So in terms of moving forward, we really do need to think about the following questions and understand better how to tackle these issues. So are our health systems gender unequal because they are weak or because they are gender inequitable? How do we disentangle these two areas of weak health systems and gender inequity? And research into Rwanda and Liberia would be really interesting. Leaders who are really pushing a strong gender focus and there's strong female leadership in both cases. What are the critical areas of intervention in the health system area? Is it health financing? Is it the workforce? Is it health information? What can we do to make change in an efficient manner? And how do we engage communities to transform gender norms and accept those transformed norms to ensure that these efforts are sustainable? Next slide, please. I'd like to reiterate in closing that the research is really, really clear. Gender equal societies are better places for everyone to live. They are more peaceful, they're more prosperous. And the health sector has a role to play in building this gender equality, and it needs to start tackling this issue. Thank you.
Thank you very much, Val, for a very clear overview of the study and explaining the specific context of gender and health systems in the post-conflict period. Before we move on, just a quick announcement. If you are tweeting, and there are a number of people who are tweeting about this, the hashtag to use is the hashtag sign HSG, that's for Health Systems Global, followed by gender, all one word, hashtag HSG. So please tweet away. And let's go now, having had the overview, to the details in the case studies, starting with Sarah Sali talking about the case from northern Uganda. Okay, Sarah?
Hello, everyone. This is Sarah. I'm presenting from northern Uganda, the experience of northern Uganda. Tim has made a good introduction of what the Rebuild Consortium is. That's what I work with. And I'm going to present findings from northern Uganda, which is part of the study areas of the Rebuild Consortium. Val has done a good job presenting what the issues of the conflict are in general, in terms of norms and values and systems. For my part, I'm going to just focus on the health-related concerns that we discovered or observed in northern Uganda. Next slide, please. Just as an overview, the northern Uganda war lasted over 20 years and affected 3 districts. And like all wars, as Val observed, there are changes that come about which affect people's livelihoods, which affect people's ability to pay for care, but which also affect people's ability to survive generally in terms of livelihoods. And what we observed in the northern Uganda war is that it created a situation of IDP camps, issues of disease. And with the issue of the IDP camps, people became more dependent on being given welfare as opposed to providing for themselves. And this in a way drove a certain kind of dependency. Next slide, please. So at the end of the conflict, what did we observe? One of the effects of the conflict was that, of course, there were a number of health-related challenges, as you can see on the slide, that were specific in terms of new illnesses or old illnesses, but more prevalent. There were also health system changes. Next slide, please. Which related to governance issues, which related to limited accountability issues, and most importantly, the healthcare system that arose after the conflict was one which had more private providers than the public providers, all the free health services people were used to during the camps. Next slide, please. Next slide, please. Some of the challenges that came about with the war, as we can see, of course, there was no infrastructure, breakdown of families, unemployment, and that entire list, as you can see it. We can move on to the next slide, please. With regard to the specific health challenges, I've observed that, but what I can add on is the situation of child mothers, more disability, and those are some of the new health challenges I mentioned, such as more amputations and more maiming, but also the psychosocial trauma. We also were faced with the condition of nodding syndrome, which is still being studied, and more communicable diseases. Next slide, please. That is just a slide to show some of the challenges that arose after the conflict. But the most important message in that slide is to show that despite the effects of the war on the general population, women's roles do not stop. For example, you can see an amputee mother, a mother with an amputated foot, but she still has to look after the child. You can see someone still having to draw water as a result of the limited infrastructure and social services that come with the war. So the effect of war, or with war, women's roles don't stop. They continue being required. Next slide, please. Another effect of the war is we ended up with a gendered workforce. And if you look at study 2, which really looked at health worker motivation, most of the people who worked during the conflict as workers and thereafter were the female workforce. But in addition to doing their work as medical providers, they also had their gender roles to take care of. Next slide, please. So what has the post-conflict situation been like? What we've observed is that despite that unique situation, the post-conflict healthcare system reconstruction has been skewed, mainly in favor of construction of physical infrastructure, including facilities and staff accommodation. Whereas this is good, it has not been accompanied with the provision of medicines and healthcare workers. There's also been an emphasis on maternal and child health and HIV services, those health conditions which can easily be managed. There has been limited effort with regard to psychosocial health care, which is an obvious thing which comes with the end of a conflict. Also, male healthcare concerns have not been prioritized. Issues of masculinity and the unique challenges males faced during that war, such as sodomy and many others. Another aspect of the post-conflict situation is that there were many female-headed households that we were observed, and most of the female-headed households were the most vulnerable in the mini survey that we did. And they were very vulnerable with regard to the fact that most of them were headed by women who were elderly and who were widows. This meant they had limited economic resources with which to survive generally, but also with which to navigate the new kind of healthcare system that had arisen at the end of the war. Because remember, as I observed earlier, the government provided services were not good enough. Because while they had the facilities, they had no medicines. Where things were a bit organized, it mainly addressed people in the reproductive health age group. So these elderly grandmothers, who also had similar household sizes like others, did not seem to have enough resources with which to navigate the new healthcare system. Next slide, please. So what are the lessons we learned? One of the key lessons learned from this process was that the post-conflict healthcare system reconstruction needs to go beyond physical reconstruction to consider other aspects of the healthcare system, such as human resources, provision of medicines, and issues of equity in access, where you have elderly people who cannot be able to fend for themselves but have members of the family to look after. The second lesson learned was that the post-conflict health reconstruction needs to go beyond maternal and child health and HIV to focus on other gender needs or aspects of the post-conflict communities, such as psychosocial trauma, men's health, issues of disability, and mental health in general. We also learned that post-conflict health reconstruction female healthcare workers to be recruited, and also to grow in their careers without compromising their household responsibilities. And the other aspect we learned was that improving household livelihoods is key to enabling post-conflict communities to access healthcare, because in the context of a privatized healthcare system, they will always need money to navigate the new healthcare system. Thank you.
Thank you very much, Sarah, for giving us this example from the African subcontinent. I'm giving a message just to remind people at the end, we very much value the feedback you provide, and there will be a questionnaire sent out, so please do fill that in at the end. And let's move to across continents to Timor-Leste, where Esther Dusabe-Richards will talk about the case study there of gender and post-conflict health systems. Over to you.
Thank you. Good afternoon, everybody. I'm Esther Dusabe-Richards, and I'm going to be talking about the case study we did on Timor-Leste, which is partly based on some PhD research that I completed in 2011, and then we carried out some latter literature reviews to bring the issues up to date. So just a brief introduction. Next slide, please. To the context. So Timor-Leste, also known as East Timor, is a half island between Indonesia and Australia that has experienced quite a lot of conflict over the years, over the centuries. It was colonized by the Portuguese for around 400 years. In 1975, Timorese political activists declared the country sovereign, declared themselves a sovereign nation. Unfortunately, just a few days later, they were occupied by Indonesian military who feared a so-called threat of a communist uprising in Timor that actually arguably wasn't there. And the Indonesian military occupied the country until 1999. During the 24 years, there was considerable Timorese resistance, and there was a global movement as well of protest to raise awareness about the situation. And those things led to an eventual UN-monitored election that was agreed upon by the Indonesian government, and the Timorese voted to have their independence, to become an independent nation. So there was a UN-monitored transition period from 1999 to 2002 when the country became independent. And there were subsequent UN missions as well to continue support in that context. There was, as I said, conflict during the 24 years of occupation, and then immediately following elections, around 1,400 people died in some terrible conflict that happened then. And in the period of independence, there have also been small, not so small, but experiences of internal conflict as well between 2006 and 2008. So that just, it goes to show that the definition of post-conflict is sometimes tricky to actually to get right. Next slide, please. So during the transition period, some of the things that are important to point out that were real challenges here, during the just directly following elections, and the conflict that happened at that time led to mass destruction of infrastructure. So there were real serious health system challenges from 1999 onwards. Also, the majority of health workers were in fact Indonesian, and there were very few Timorese nationals who had been trained up in healthcare. So the majority of human resources actually fled the country following 1999, so that was a huge barrier. However, there was really important progress made in the early 2000s with the support of the UN, with the support of the Timorese partners, also international and local NGOs, and importantly the Catholic Church, who collaborated to help support the health system. In the case of the Catholic Church, mainly through their own clinics that they ran prior to independence and following independence. So in parallel, a lot of energy was generated by local women's organisations and also other important agencies working local and international, working in Timor, to highlight really the key role that gender equality should play in the new nation. So that was a really positive aspect of independence. Next slide, please. So this led to some really important steps forward when looking at gender equality and equity and its role in the reconstruction of the health system. So for one thing, gender focal points were appointed across 4 ministries: health, education, agriculture and justice. And there was the establishment of what eventually became the Secretariat of State for the Promotion of Equality, but which started off as the Gender Affairs Unit as part of the first UN mission. Now that was the first Gender Affairs Unit of any UN mission. That became the Office for Promotion of Equality, that then became the Secretariat of State for the Promotion of Equality in 2007. So that was quite a visible step, really, to highlight the importance of gender equality, first by the UN mission and then subsequently with the partnership of the Timorese government. And one of the really important changes that was made was that the penal code that was ratified in 2010 included a law on domestic violence, really in recognition of a lot of work that was done in the independence, early independence era, to recognise the level of gender-based violence that existed in Timor, and the fact that it was fairly tolerated so in society. So this law was represented a lot of hard work by lots of different agencies and organisations and the women's movement. Next slide, please. And as always, you know, inevitably there were real challenges despite some of this progress that was made. And there's an interesting thesis that's recently been completed that looks specifically at the UN's approach to gender mainstreaming in Timor, and you know, critically analyses that process and finds, as I've said, many positive aspects, but also some flaws in the process, particularly around how certain aspects of gender equitable principles were really lost in translation, partly really through language issues and also through the fact that there was a real focus on specific groups of women, so urban elites, who became the kind of recipients of certain interventions, that then perhaps that the language of gender equity wasn't properly translated and integrated into work done across the nation with different groups, women, men, boys and girls, in representing different strata of society. And Timor had suffered and was suffering during the early 2000s a very high burden of maternal infant mortality, and that really required a lot of energy and focus to be on maternal and newborn health, and of course with an emphasis on sexual and reproductive health issues. But that of course led to inevitably, again, a lot of focus on gender equality and equity being around those issues, which, you know, Val's already discussed how that has happened more generally, and we saw that in northern Uganda as well. And I think, again, gender-based violence issues were also seen as kind of the main aspect that the work on gender was meant to address. So that was really a challenge. Next slide, please. And just to mention as well what I've called complicating factors, but Rich, I guess that's a bit of an understatement, but some of the other issues, other factors at play, as I mentioned, there were internal conflicts that put a huge strain on the health system that was just starting to be rebuilt, reconstructed in the early 2000s, and then the conflict that happened that was due to kind of internal political struggles led to 150,000 people being displaced. It led to IDP camps, it mainly focused around Dili, the capital. That had a massive impact on the health system and on other aspects of the reconstruction. And as I mentioned, that some of this was based on research that I undertook for my own PhD, and that was actually looking at the role of the Catholic Church in East Timor. It's a very Catholic country, and the Catholic Church is a really significant partner working with the Ministry of Health, and some of that has been extremely important to ensure continuation of services for the population. However, I found that in the area of sexual and reproductive health, the Church had considerable influence in some areas of sexual and reproductive health policy. This is particularly seen in the area of abortion. The penal code that I mentioned before initially reduced restrictions to abortion. That was based on very hard work done by the women's movement, but a few weeks before ratification, amendments were added to criminalise abortion under almost all circumstances, and that was directly due to pressure put on by the Catholic Church through some individuals. So those are really some extra factors that have impacted on how gender equity was integrated or not into the health system in the post-conflict era in Timor-Leste. Next slide, please. So in conclusion, you know, although there were really important steps taken in the post-conflict period to both rebuild health systems and in parallel to mainstream gender across various areas of government, gender arguably has been mainly associated with, as we've seen, sexual and reproductive health, maternal and newborn health, and perhaps not so much in the health system, but more generally associated with gender-based violence issues. And these are extremely important, and they've been extremely important to address in Timor, partly due to the heavy burden that women have borne in terms of their reproductive roles. However, this focus then has taken some emphasis away from the opportunity to build broader gender-sensitive approaches across the health system and to address other dynamics and other issues that are affect women and men and boys and girls. So in conclusion, albeit that progress has been made in Timor-Leste to integrate gender into the health system, I would argue that, and we would argue from the case study that we carried out, that this has taken place within fairly narrow parameters. Thank you.
Thank you very much, Esther. So we started with a broad overview of the issues and the study, what it was trying to achieve, and now we've had two quite detailed presentations of the country case studies. And just to remind you that these are written up along with two other case studies and are available on the buildingbackbetter.org website. So if you wish to go and look at those afterwards, please do. We have about 10 minutes for questions before we close. What I've been trying to do as the presentations have been going on is to distribute these to a number of our presenters via Skype. And the first one is directed at Val, and the question comes from Alvaro Alonso Garballo, and he says, first of all, he says, Happy Women's Day to all, thank you. And his question is, multisectoral approach is paramount here. What is, from your experience, the role of schools in promoting gender-sensitive attitudes in the early stages of development? What are the approaches that work? Val, would you like to offer some thoughts on that?
Okay, thanks very much, Alvaro, for that question. The education sector is not something that I've looked at specifically, but I would just like to reiterate that ideally the would be a perfect opportunity for to address some of these gender norms that are driving violence and risk-taking behavior among boys and men, etc. But one of the things that that I found, at least in the case of Mozambique, is that schools can be actually a place where girls experience a lot of abuse. So I found one study, and it's very, very difficult to get good data on this, but one study interviewed a bunch of girls going to school, and 70% of girls report that they knew that teachers used sexual intercourse as a condition for promotion between grades. 50% said that both teachers and boys in their peer groups had abused them. And so some of that abuse is one of the reasons why a lot of girls don't finish school. So I haven't looked at the education curriculum and to see exactly if and how you would address that kind of issue. Ideally, it would be a good sector to try and change gender norms. But sadly, it seems, at least in the case of Mozambique, to be a place where those gender norms are really entrenched, and violence against girls is quite prevalent. Sorry, I'm finished. So I don't know if anybody wants to take over in terms of the next question.
Sorry, I was on mute.
Sorry. Okay,
yes.
sorry.
So let me just take the questions as they come. This one is for Sarah. If you could answer this question from Sretushbong from Cambodia. I believe she's in Kilifi in Kenya at the moment. She says, how to engage community in changing gender norms in building equitable health systems. Have you got that, Sarah?
Oh, yes, I have.
Thank you.
Thank you very much, Tush, for that question. I think communities offer a very good opportunity. Community engagement is a very good opportunity for people to change gender norms. But for this to happen, I think communities have to be engaged in reflecting why the war happened in the first place, where are they now, and where do they want to go. And if within that process, gender is mainstreamed, it provides a perfect opportunity for the community to rethink its past and to rethink its future, or to reshape its future. Unfortunately, most post-conflict systems or reconstruction efforts do not look at that aspect. They are more concerned with the more physical things. How many bridges do we need to construct? How many more schools do we need to put up? How many more hospitals? And once that is finished, boxes are ticked and the process is ended. And I think in Uganda's case, we seem to have lost that opportunity. If you compare it with what happened with the South African Truth and Reconciliation Commission, it was not really a gendered process, but at least it gave people an opportunity to rethink race and why things had turned out the way they went, and how to refashion a new South Africa. So communities engaged in such reflective processes provide good opportunity for reshaping gender norms to more sensitive gender norms. Unfortunately, post-conflict reconstruction efforts never go there. They focus on the physical things and leave out that, but it needs to be done. Thank you.
Thank you very much. Esther, did you get, are you ready for question 6? Esther, are you there?
Yeah, I'm here. Yeah, question 6. Sorry, let me just have a quick look at the sky.
Well,
yeah, so...
Okay, let me read it out then.
Samuel
This is from Samuel Okara from AMREF, also from Kenya. He says, what strategies or tools exist to address changes in gender relations in post-conflict contexts? Thank you, Esther.
Okay, thank you. Well, Val mentioned this a little bit, that there has been work done to integrate women into peace building existing structures. So there was a recognition that women had been left out of peace building processes, and so there was a considerable work done to try to integrate women more into that, and to try to address women's lack of political representation. So that's something, again, that Val mentioned. But I think what we found from the work that we did is that there is a lack in terms of trying to address the health system itself. So strategies, again, there are interventions in the health sector that exist. So there's structural interventions to try to address gender, to change gender norms. For example, stepping stones is an example of that. There's important work done by NGOs all over the world, for example, Gender Justice in South Africa, to address gender norms and to try to change gender relations in different contexts. But what we didn't find is something that really helps and guides in the post-conflict reconstruction moment to guide the development of a health system that takes into account gender equity, and that really develops gender equitable measures in the health system to be able to make those changes across more broadly to address gender relations. And obviously this work it can't be just the health system, but one aspect of the work needs to be within the health system. And what we found was that there wasn't really anything that spoke directly to the health system. So the strategies were more around peace building and to engage women in political processes, which is vitally important, but that they needed to be more directly related to the health system reconstruction to ensure gender equitable outcomes there. I don't know if Val wants to add anything.
Val, would you like to add?
I'm sorry, I think maybe I won't add anything. I would just recommend that people go to the website and take a look at some of the publications there, and then that also gives us opportunity to answer more questions.
While you're there, Val, thank you very much, Esther. While you're there, Val, there was a question directed to you about your cartoon. This is from Tumaini Nyambanga from Tanzania. He says, the cartoon that said, "This is not a mess, it's an opportunity." He says, can you please unpack this? How are post-conflict is that okay?
Okay, yes, that's excellent. That's a very good question. Thank you very much for that. I think we often think about the post-conflict period as being a depressing place where health systems and health infrastructure, if it hasn't been directly destroyed by conflict, it's definitely been neglected. The economy is weak in conflict-affected states, so there just isn't the money going into health systems. And so what happens as you emerge out of that post-conflict period is that it provides space for change. There's often a lot of donor resources available, or at least more than are normally available. There's energy from civil society activists. There's a space for their engagement. Often donors will facilitate, hopefully, consultation with civil society, with the health system and health care workers. And the political process can also be more open to change. So things like national insurance programs or health financing which might be tricky to get through in a normal political time space, in the post-conflict period, there's that opportunity for change. But one thing I'd just like to mention, when you're looking at that process and how health systems, gender is integrated into health system reconstruction and reform, I would just encourage everyone to go beyond looking at whether or not donors and ministries of health and health workers engage in language about gender, and look at some data to see whether or not those indicators have moved. Because what I found this once, particularly in the Mozambican case study, there was a lot of effort and a lot of symbolism around gender and around women and among women's empowerment. But then once you looked at the health indicators, you saw, how difficult the situation remained for women and girls, the vast majority of women and girls in Mozambique. So we need to kind of go beyond the rhetoric of gender empowerment and see whether or not that's actually making a difference in the lives of real people. Thank you.
Very much, Val. We've got lots of questions coming in, but we've really only time for one on this webinar, but we'll be posting the others and trying to respond. I'm asking Sarah to respond to this from Uchi Aberi. He says, alongside the need for more focus on maternal, child and reproductive health, there is a need to balance focus around issues bothering the wider population, which includes men of all ages. Sarah, what are your thoughts on that?
Hi. Thanks a lot for that question. I could actually not agree more with Uche. I think he's very right. As we observed earlier, there are issues of weak health systems, which is a function of war and conflict, but also within that are gendered issues. So it's very important that we build health systems that respond to wider population issues. And that's our major critique of the focus on MCH and HIV. While those are important, all the other things are very important. And if I can just tie this in lightly with the question on Alvaro, we've identified several issues men faced, as well as women who are not in their reproductive health ages. Things like orthopedic concern, things like psychosocial trauma, males who had been sodomized during the war, and general concerns of malaria and the like. So just coming in and focusing on MCH and HIV to the exclusion of all those other things, I think it's not fair. So it's very important that we work on wider health system things that benefit the majority of the population, while also paying attention to the gendered issues within that. It's not enough to just work on MCH and HIV. And I think if we can do that and do it very well, then all the other concerns will be brought on board, things like GBV, instead of relegating them to NGOs and all the other aspects of health. Thank you.
Thank you very much, Sarah. That's a very good point to end on. So thank you to all of you for attending, giving up your busy day, and also I assume there are a lot of other competing events for the International Women's Day. We will share the remaining questions to you. We'll send information about the RINGS Consortium and the thematic working group. And we hope that we'll be able to keep in touch with you. The researchers are very interested in continuing this dialogue. And it remains for me to thank all the panelists very much for giving up your time and giving very informative presentations, and I think generating a lot of questions, as we can see here. Let me also thank Kate Hawkins and the RINGS group for organizing this, along with Natia from who's based in the Health Systems Global Secretariat in Tbilisi, who's been operating the slides and operating all of us, making sure that we were all ready and can provide a professional webinar. So, thank you and good day.